Thank you for inviting me here to talk. So I wanted to talk about diplopia when patients come to our clinic complaining of double vision, because actually double vision can be anything from something very, very simple and unconcerning, like the cornea not being round as one would expect and having astigmatism, all the way to having a deadly brain tumor that needs urgent surgery. So diplopia, it's a very interesting topic in the way that it covers a wide range of causes and a wide range of structures that can be compromised. So the first thing and the most important thing that we want to know when somebody comes into our clinic and says, I have double vision. The most important question we want to ask and what we want to figure out is whether the double vision is the result of the two eyes being misaligned versus having double vision produced in one eye or the other eye. Why? Because we always say if the double vision is monocular, that means that is not because the two eyes are looking in different ways, but actually produced in one of the two eyes, or sometimes it can be in both eyes, but we will see how to differentiate them. But the point is, if it's monocular, it's refractive. That means the cause is how the light behaves inside of the eye, and it can be fixed with glasses, it can be fixed with contact lenses, it can be fixed with cataract surgery, it can be fixed addressing the cornea. But if it is binocular, that is when we think, okay, this is something more neuro-ophthalmologic. It's got to do with the nerves, it's got to do with the muscles, it's got to do with the brain, okay? So to differentiate this, because patients will come and tell you, yeah, the double is in this eye. It's very hard to know whether the double is in one eye or it's the result of the two eyes being misaligned. What we want to ask, if the diplopia is binocular, which is the concerning type of diplopia, is if it goes away covering either eye. Because if it's binocular and you cover one eye, you shouldn't have double. Or if you cover the other eye, you shouldn't have double. However, if the double vision is produced inside the eye, you cover maybe the issues with the right eye. You cover the right eye and you don't have double, but you cover the left and you still have double, okay? So that is the main question when you see somebody with diplopia, whether it is monocular or binocular. And as I said, like, don't base on what the patient said, because the patient will tell you, yeah, the double is in this eye. No, the differentiating question is, does it go away when you cover either eye? If it goes away covering either eye, then it's binocular. And one clue, usually when, if images are fully separate in space, it's usually binocular. Because if it's going to be caused by a refractive issue, they usually see like a ghost. They usually see overlapping images. So that is another question that can help you if they go and tell you directly, no, I see two separate images, like the mirror is here and here, or up and down. It probably is binocular. So that's the most important question, because if it's monocular, as we said, chances are, by far, this is refractive. And the most common cause of refractive diplopia is what we call astigmatism, which is that the cornea, the shape of the cornea, is not what it should be. It's deformed horizontally or vertically, and that is going to give us a ghost image. So I put there a photo of the cars. On the left is The actual image on the right is when they have astigmatism, the way they see, and that can be interpreted as a ghost image or a double vision. Another cause can be cataracts. So I put out the photo down below there. It's a lens, and you see those two white opacities in the lens. Those can cause the light to refract in a way that projects as a double image on the retina, okay? So this is the main cause for monocular diplopia. And when we figure out this monocular, everybody relaxes because we know it's not gonna be something sinister. Now, if the double goes away covering either eye, then is when we start, going forward and asking more questions about this double vision. And it is caused by the eyes not being aligned. So here I put 3 photos of the main types of misalignments that you will see. So if you see the photo up to the left, one of the eyes is looking out. We call that exotropia. The other photo, the eye is looking in. So the eyes are crossing in. That's what we call esotropia. And then the photo on the bottom, one eye is slightly looking up. That is hypertropia. Or if you consider the other eye is looking down, it's hypotropia. And those manifest as double vision. And there, when it's in the horizontal plane, the images are going to be separate horizontally. And when the eyes are misaligned vertically, the images are going to show oblique or pure vertical, okay? So what do we want to know about diplopia? When a patient comes in, first, is it monocular or binocular? But then we want to know, when was it first noticed? And if we can get to the actual date, it's even better. What was the patient doing while they noticed the diplopia? Because as we will see, depending on the cause of the diplopia, when they noticed it, it's going to give us a clue. If it's by the end of the day when the patient is more tired, it's going to make us think of things like, for example, myasthenia, which is when the muscles don't talk well with the nerve. However, if it's noted first time in the morning, that's going to be less suggestive of that. If it's something that starts suddenly, we can think of things that occur more acutely, like a stroke. If it's more progressive, we can think of things that are, for example, like a tumor that can grow, and it can take time for the tumor to start causing symptoms. And another thing that we want to know is whether this was related to head or ocular trauma. Because of course, trauma can cause injuries to the muscles, injuries to the nerves that go into the muscles. So we want to know whether they had trauma before. What else do we want to know? Is it there all the time, or is it there intermittently? When the diplopia is there intermittently, then we think of things like, for example, myasthenia. But if the misalignment is constant, then the double should be constant. What happens sometimes is that one eye is so misaligned, or both eyes are so misaligned, that one image is so far away that sometimes they can neglect that second image, okay? Has it gotten better or has it gotten worse since this started? We want to know how things are evolving. Is it getting worse quickly? Is it pretty much the same? Has it been the same for the past 2-3 years? Okay. And how does it behave throughout the day? As I said, myasthenia is usually worse by the end of the day. Are the images separate horizontally, oblique, or vertically? And are they always in the same position in space? Because if they change, that also gives us a clue on what can be causing this double vision, okay? And is it better or near? Some people don't have double for near because their eyes are crossing in and only notice it for distance. So they will tell you, no, I notice this when I'm driving, but then when I read, I don't have double. Why? Because when we read, we converge. And so if the crossing is inwards, it's an esotropia, then maybe for near, you don't have double. So that is another question that will give us clues on what is going on. So here I put a slide just to show you the muscles that move the eye in the different directions. There are 6 muscles around the eyes. So you will have the muscles that are in the horizontal axis, which is the lateral rectus and the medial rectus. And as you can imagine, the medial will move the eye in, the lateral will move the eye out. Then you will have the 2 muscles that are in the vertical axis, which is the superior rectus that is going to move the eye up, and the inferior rectus that is going to move the eye down. And then there are 2 extra muscles, which are the oblique muscles that they insert superiorly and inferiorly and have an oblique force. And what they actually do is the superior oblique is the one that we mostly use when we read. So it makes the eye look down and in, actually out, down and out. It's mainly a rotator. So it rotates the eye in and makes it look down. And it's got another function that is not as important. And then the inferior oblique that does the opposite, okay? So depending on which muscle is affected, or which nerve going into the muscle is affected, or the brainstem where the nuclei are for these nerves that go into the muscles, is what is gonna, how the double is gonna present, okay? So another thing that we want to know, that photo is cute, but actually what I want to show you is that the kid is tilting the head. When we see a kid that is tilting the head, we have to have a suspicion that he might have a misalignment, okay? So is the person like tilting the head in photos? Do they deliberately tilt the head? Is there a history of lazy eye or strabismus? Does the person have a history of eye surgery for lazy eye or for strabismus? We want to know that because that is going to change the way the eye moves. Another important question is there pain? Is there pain when the patient moves the eye? Is there bulging of the eye? Why? Because there are some inflammatory or infectious causes that can cause what is called cellulitis, for example, that may present as double vision, okay? Does the patient have headaches? Why? Increased pressure in the head can cause double vision, okay? Or tumors in certain locations can cause double vision. So we want to know if the patient has headaches. And when we're asking about pain, and I'll go over this very quickly, you want to know the onset of the pain, what makes the pain better or worse, what kind of pain they have. Is it stabbing? Is it burning? Is it pinching? Is it a dull pain? We want to know where the pain is exactly. Is it behind the eye? Is it around the eye? Does it radiate to the head? Does it radiate to the face? We want to know how severe the pain is from 1 to 10, 10 being the worst pain that they can ever imagine. How long has the patient had pain? And is he getting treated for the pain? Is he taking any medication? And then understanding how the pain is impacting the patient's life is always important. And then some causes, some specific entities that will cause double vision that I wanted to give you a notion of. So myasthenia gravis, as we said, It's a condition in which the nerve is not talking correctly to the muscle. So we want to ask, so they may manifest with different symptoms that in a way translate this difficulty with muscle contraction. So is the patient having difficulty breathing? Is the patient having difficulty swallowing? Is it, does their voice change? Is it hoarse? Is it more nasal? Okay, do they have difficulty producing the voice? Do they have significant muscle weakness? If we ask the patients, do you feel weak? Most of them will say yes. But we want to ask, is there a noticeable change in your strength? Okay, is it a significant muscle weakness? Because all this are symptoms of what is called generalized myasthenia. So other than the double, which is ocular myasthenia, they may have symptoms of generalized myasthenia, and that is going to give us a huge clue on what is going on. Another thing that we always want to ask when patients come for double vision and they're over 55, because this very, very, very exceptionally happens in people under 55, is something that is called giant cell arteritis, okay, which is a swelling of the walls of the arteries, and it can have very, very serious consequences. So we want to ask if it manifests as tenderness of the scalp. So they touch the scalp and it's tender. When they're combing their hair, when they're brushing their hair, they feel it's different on one side compared to the other one. So we want to ask that. Is it painful when they chew? And many people have TMJ and they have pain when they chew, but this is a specific pain that at first is okay, and then it builds up and it's more painful as they chew for a longer time or harder, like food that is more difficult to chew. Okay, for example, when they're eating steak, it's going to produce more pain. Okay, are they losing weight involuntarily? Have their headaches changed? Because most people have headaches, but are the headaches different? Are they worse? And are they having night sweats? Are they having fever? So those are things that we want to ask when people come for double vision and they're over 55. So basically that's all I wanted to share. As you see, when we have a patient with double vision, the questions are very, very, very important. And if you know what you're asking and the reason why you're asking this, it's very rewarding. So I think NeuroOph, it's very much fun. You should definitely consider joining us. We're always open to, increasing the, getting new team members. So you're more than welcome.